see. Okay. All right. So we're going to talk about a couple things today. I'm going to start very briefly with acute coronary syndrome pathophysiology. Then we'll talk a little bit about first medical contact. I'm going to talk to you guys a little bit about the initial triage of chest pain syndromes. Not necessarily because I think you'll be doing a lot of that. That's really more germane to internal medicine doctors who are doing admissions to an observation unit or to the ER. I still think it's good because it sort of creates a picture of the entire spectrum of acute coronary syndromes. And then we'll talk about the upfront management of acute coronary syndromes, which is probably the most important thing for all of you. So in terms of pathophysiology, you are all a lot closer to medical school than I am. These may be very old pictures from older textbooks, and I think you all know this already. But the big distinction is that an acute coronary syndrome is most typically characterized by plaque rupture with secondary thrombosis. The STEMI typically represents transmural ischemia, and that rapidly leads to infarction with a resultant Q-wave myocardial infarction. Non-STEMI usually leads to non-Q-wave myocardial infarction, and typically there is not a complete occlusion of a vessel when you have a non-STEMI. And then by definition, unstable angina is not associated with actual infarction. So it's very rare nowadays that we see or diagnose true unstable angina because we have such sensitive troponin, right? So we can almost always detect some biochemical abnormality that suggests an actual infarction. And our definition of non-STEMI is much more liberal than it used to be. Right? But that's the general spectrum. Now, first medical contact. This is typical Cumberland County, right? Smoking a cigarette while shoveling snow and then collapses, right? So the first important decision is this a STEMI or not? Okay. And why is that the most important initial decision? I mean, it's not a trick question, right? Yeah, because you're talking about immediate reperfusion therapy. All right. So the American College of Cardiology, American Heart Association guidelines that relate to emergency medical services, they really push for a good system, right? They want to see an EKG in the field, and then they want patients transported to a PCI capable hospital. Now, for all of you who were training here 10 years ago, which is none of you, you would have recognized what a problem it was because it was a new program. Patients were going to Elmer, they were bypassing Vineland and being driven to places like Cooper or Atlanticare. Now our EMTs are very good at identifying STEMI in the field, sometimes notifying us ahead of time. Sometimes there's a little ambiguity to it, and getting the patients to this particular institution. All right. And the goal is really a first medical contact to reperfusion time of 90 minutes. Now, we don't track that goal because, when we have a patient who's buried, somewhere, in Cape May County or in Salem County, they're not going to get here in 5 minutes. It's going to take 20, 30, 40 minutes sometimes. And then, we mobilize the cath lab and whatnot. But door to balloon time of 90 minutes is a very achievable goal. And it's one that we work very hard to consistently meet. All right. So this is the algorithm from the ACC guidelines. So STEMI, all right. STEMI is important because those are patients who are candidates for immediate reperfusion therapy. Okay. They go to a PCI hospital. All right. The number is 90 minutes. All right. We want a door to balloon time of 90 minutes. Shorter is better. Okay. We want 90 minutes though. Now, what if they go to a non-PCI capable hospital? How do we determine whether we're going to transfer those patients out, all right, or whether we are going to give them thrombolytic therapy and then manage them medically or transfer them out for a more elective procedure, all right? So the time then becomes 120 minutes, all right? So you want a door to balloon time, so door of the initial hospital to balloon time in the receiving hospital of less than 120 minutes. If you can't achieve that, then you want a door to needle time for thrombolytic therapy of less than 30 minutes. All right. Fortunately, our patients who present in system, patients who go to Elmer, we are pretty consistent in getting door to balloon times, Elmer door to balloon time here in Vineland of under 120 minutes. And in fact, most of the time we're under 90 minutes. So using that type of transfer modality is perfectly appropriate. All right. Um, there are places where they still have to give thrombolytic therapy, middle of the country, where they don't have primary PCI centers. All right. And if any of you end up practicing in a place like that and taking care of patients with thrombolytic therapy, remember the goal is 30 minutes from door to needle. All right. And then afterwards, most patients who receive lytics still undergo cardiac catheterization. So there's a recommendation that they be transferred and that they undergo revascularization. It's called it's called an invasive strategy, usually 3 to 24 hours after they get thrombolytic therapy. So you don't have to do it immediately. You have that window of time to let the lytic effect mitigate a little bit for when you get arterial access, and also you allow for transfer time, and then you do it quasi electively in that 3 to 24 hour period. On the other hand, if you give somebody thrombolytics and they don't reperfuse, or they do reperfuse and then their reperfusion and then they appear to reocclude, you want to get them more urgently out to a cath lab. Typically when you give someone thrombolytic therapy, you expect the STs to go down by at least 50%. You expect them to have some worsening of pain when they reperfuse, and you also look for a reperfusion arrhythmia. Um,
How fast after giving do you expect this?
Usually within probably, it depends on the lytic you use. Now with tenecteplase, it's a one-time bolus. You probably want to see it within 30 minutes. Yeah, definitely within 90 minutes. All right, so this is just the summary. I will, I'll not go through all of it. It's just a recap of what I just said for PCI and for thrombolytic therapy. But I do want to point out a couple of things that more relevant for you guys specifically. So down here under PCI, okay, STEMI with cardiogenic shock or acute severe heart failure, you want to get that artery open irrespective of the delay to presentation. Okay. So the most benefit for PCI is in the first 12 hours. All right. You can see up there under where it says class 2A, there is a benefit 12 to 24 hours with ongoing clinical or ECG evidence of ischemia. But the time frame goes out the door if they present in shock or if they present with acute severe heart failure. If they had pain 2 days ago, STs are up, they have some Q waves. Clinically, it's pretty clear when you talk to them that their pain was 2 days ago, they infarcted 2 days ago, but they're in cardiogenic shock. You do a quick echo, you don't see a mechanical complication that needs to be fixed. All right. Then you can go ahead and you can, you're well justified in trying to get the culprit artery open. Okay. We very rarely give thrombolytic therapy in that 12 to 24-hour window. All right. If patients come in with hemodynamic instability, or there's a large area of myocardium at risk, so it looks on the EKG like it's an anterior wall involving the proximal AD, or you do a POCUS and you see the entire anterior wall is down, you would consider lytics if you're in the middle of nowhere and you don't have a cath lab. All right. Otherwise, the idea would be to take them to the cath lab. Mm-hmm.
What prices would you recommend?
So, and by the way, I'm happy to give you guys a shock lecture. I have one that I give, and we talk about mechanical support. Okay. It's pretty clear that norepinephrine is the drug of choice in patients who have acute coronary syndromes and cardiogenic shock in general. All right. There was randomized trial, the SOAP2 trial, right, which compared dopamine with norepinephrine. And if you look at the cardiogenic shock subgroup, there was a mortality benefit with norepinephrine. All right. I don't think that means norepinephrine saves lives. I think that if you are using a pressor, you're less likely to die if you're on norepinephrine than if you're on dopamine. All right. Probably less arrhythmias, less tachycardia, things like that. So that's my pressor of choice. I like to avoid, dopamine because of the arrhythmogenic effects, although sometimes, patients who are markedly bradycardic or in heart block, I may choose to use it, but it's very rare. They usually can't tolerate things like milrinone alone. And I'd really like to avoid neosynephrine because of its afterload increasing, capacities. Most patients with cardiogenic shock in the shock trial had PA catheters, and that can be very, very helpful, but there's no randomized data that PA catheters save lives, right? But 95% of patients in the original shock trial had them. So, we often use them. And then we start thinking about mechanical support. Although the only thing I'll say about shock, well, I'll say whatever you guys want, but the only additional thing I'm going to throw in about shock, and we can talk about, shock in more detail at another time, is that the only thing that saves lives in cardiogenic shock secondary to MI is revascularization. That's the only thing that's been shown to save lives. All the other stuff that we do all the time, choosing a pressor, putting in a PA catheter and deciding what kind of fluids or inotropes to use, putting in balloon pumps, putting in impellers, thinking about ECMO, none of those things are proven to actually save lives. Okay. This is a pretty neat case, okay? Just to remind everybody that thrombolysis is still used today. All right. So 44-year-old nurse who was staffing a remote nursing post in Coral, Australia, developed chest pain. All right. He was 150 kilometers from the closest hospital, and he was 1,000 miles from Perth, which was the largest city. He performed and then emailed his ECG to their emergency telehealth service. And his initial ECG, you can see it up here, showed sinus rhythm with third-degree AV block and ST elevations. And then his second EKG after the heart block resolved showed sinus tach with inferior ST elevations and reciprocal changes in V1, V2, and V3. So he self-cannulated both antecubital fossas. He placed defibrillator. Yeah, I'm not making this up. Look, New England Journal of Medicine, right? He put 2 IVs in himself. He took aspirin. He took Plavix. He took a sublingual. He gave himself heparin and opioids. He had amiodarone, epinephrine, and atropine nearby, and he self-administered tenecteplase. His ST elevations resolved. They picked him up in a helicopter. They took him to Perth. On day 2, he had a left hard cath. He had a severe right coronary lesion, but it was open with TIMI-3 flow. He received 1 drug-eluting stent. He went home 48 hours later. Right? How about that? Somehow he got it done. I'm not even sure he needed 2 IVs, honestly. Yeah. All right. Let's talk about the initial triage of chest pain syndromes. All right. You guys don't get as much of this in the ICU, thank God, but this is like typical day in the ER and a typical day in the in the observation unit, right? Complaining of chest pain, shortness of breath, cramps, and dizziness. Do you sell earplugs? I don't blame her, honestly. So this is the type of algorithm that you will see in the ACC guidelines and in textbooks and on UpToDate. And I think that what our emergency room physicians and our internists often do not do is simplify that and ask a couple of key questions so people like us who end up managing the sick patients in the hospital have an easier time sorting out who's actually sick and who's not, right? So the first most important thing to figure out, right, is does the patient meet criteria for immediate reperfusion, right? But we already talked about that. Let's say the patient doesn't, all right? Number 1, is there any objective evidence of ischemia, right? So you'd be looking for transient ST deviations greater than 1 millimeter, T-wave inversions, particularly in the precordial leads, arrhythmia, signs and symptoms of heart failure or MR, elevated biomarkers, okay? Number two, is the pain typical of angina? All right. Number three, if the pain is typical of angina, is the mode of presentation consistent with more chronic stable angina, or is it more consistent with an acute coronary syndrome? So, typical angina, or how about pain that's not typical of angina? Sharp, well-localized pain, pleuritic pain, epigastric burning, pain that's reproduced with palpation, and this, I think, is really, really important. I don't know if you guys hear this a lot, but I hear from the ED all the time. Patients got a great story. What's the story? Substernal chest pressure, radiating to the jaw, radiating to the left arm. Okay, yeah, that sounds like angina, right? When did it start? 4 days ago. Okay, does it happen every time the patient, walks? Oh, no, it hasn't gone away. Ask the patient, I'm on the phone with you, ask the patient, has he had any pain-free period in the last 4 or 5 days? No, not 1 minute. I can't sleep. I've had it persistent. I go, all right, well, this could be pretty serious. What's the EKG look like? It's normal. What's the troponin? 0. I say, it can't be angina, right? It just can't be. It's like saying, this guy has a piece of concrete that fell on his leg, and you look at the leg and there's no concrete there, and you say, well, the leg's not crushed and there's no concrete. That can't be what happened. But he's got a really good story for that having happened. I mean, it just doesn't make any sense. You can't have unremitting chest pain for days and days and days and days and have a stone cold normal EKG and a negative biomarker. Now, it takes a little sorting out, right? So, I mean, patients report things oddly sometimes, and they're not the best historians always. So you really have to, if you had any pain-free periods, is it only when you do activity? If somebody has low-level chest pain, they walk across the room, they get chest pain, and then they sit down and the pain goes away within a minute, their biomarkers may be negative, and that could be a really unstable plaque. So it's important to sort of sort that out, but long-lasting, unremitting chest pain with negative biomarkers is probably not angina. And I just sort of went over this, but everyone kind of knows what the more typical symptoms are. Exertional, relieved by rest, when it's in a stable pattern. One thing that people sometimes don't realize is the unstable syndromes are the ones that are usually associated with autonomic symptoms like diaphoresis, nausea, vomiting, So, if somebody has chest pain and they get very nauseous and they get very diaphoretic with it, that's much more likely if it's, angina, it's much more likely to be an unstable syndrome than it is to be a stable syndrome. Okay. And, unfortunately, as much as I'd like to tell you that, you can make the diagnosis of angina just with history, you have to take it with a grain of salt, what I'm saying, because there are people who present with very atypical symptoms, abdominal pain, GERD, shoulder pain, and it's not always perfect. And then, we kind of went over this already, but once you've taken a look at them, and let's say they have no objective evidence of ischemia, right? And they have a description of the pain that's reasonably consistent with angina, you have to think a little bit about what the mode of presentation is. So, chronic stable angina is predictably precipitated by activity or stress and goes away with rest, whereas, acute coronary syndromes, they will be long lasting, or they will occur more frequently and at lower exertional thresholds. So, a typical, description of unstable angina might be somebody who has a known lesion or a known chronic total occlusion of a vessel, who exercises regularly and notices that he gets his angina when he does a mile on the treadmill, and, he takes a sublingual nitro and feels better. And then all of a sudden, every time he walks across the room, he has chest pain, but it gets better when he sits down and rests. that's unstable angina. And it may be from an acute, plaque rupture, but it may not be sufficient to cause infarction. Pain that is prolonged, greater than 20 or 30 minutes, you're almost always going to see some biochemical evidence of infarction, and that would be considered a non-STEMI. So just by definition, possible acute coronary syndromes are concerning symptoms, but we don't yet have objective evidence of ischemia, whereas definite ACS is where you have that objective evidence of ischemia, right? And that would include STEMI, non-STEMI, and unstable angina. So, just to kind of recap, right? The most important thing is looking to see whether a patient up front meets immediate criteria for reperfusion, right? So is it a STEMI? If it's not a STEMI, do they have high risk features and objective evidence of ischemia, right? So, I'd be much less worried about a patient who comes in smiling and laughing with mild chest pain and inferior ST elevations, and much more concerned about a patient who comes in with a blood pressure on 90, gasping for air, with altered mentation, who's got brand new deep T wave inversions across the precordium, right? One's a STEMI, one's not, but the second guy is higher risk, right? So we're looking for immediate reperfusion criteria, then we're looking for objective evidence of ischemia, and then after that, we can take a step back and we can decide whether the pain is consistent with angina or not. And if it is, we can think a little bit about what the mode of presentation is. Does it seem like stable angina? He just, someone made him nervous and he decided to come in today. Does it seem like unstable angina? Or do we think, or do we think it's something completely different and atypical? All right. So anyway, that's the general approach to chest pain and to sort of distinguishing the types of acute coronary syndromes. Now let's talk a little bit about ACS management. All right. So STEMI management, we already looked at this. The key is reperfusion, right? This I'll leave for you guys in the slide set as a reference. You will not be using a lot of thrombolytic therapy for STEMI in this hospital. Almost everybody's going to go to the cath lab. Once in a rare while, we'll have two simultaneous cases and we'll consider it. While there are a few different available thrombolytic agents, most of the time tenecteplase is used because it's administered as a single weight-based bolus. It's not antigenic. Streptokinase, which hasn't been used regularly in decades, is antigenic. If any of you go practice overseas in third world nations, you might see streptokinase used, but otherwise you won't. And it, some of the other ones, has a pretty good fibrin specificity, which means it doesn't degrade fibrinogen, so there's no systemic lytic state that occurs after you use tenecteplase. It's given as a single weight-based bolus. Now, again, this will just be here as a reference for you, but thrombolytics, you may use them for CVA, you may use them for, PE, depending on where you're practicing. The absolute and relative contraindications are usually the same for all these disease conditions. Remember that if, someone comes in markedly hypertensive, that's not an absolute contraindication. Just like you would with a CVA, you want to lower the blood pressure a little bit and then be able to give thrombolytic therapy. All right. We'll talk more about adjuvant therapy for most patients who are coming in for non-STEMI management in a moment. All right. But for STEMI, it's a little different. All right. Everyone obviously gets aspirin. All right. And for STEMI management, if we're giving, thrombolytic therapy, the only second antiplatelet which is technically indicated as an adjunct to thrombolytic therapy is clopidogrel. All right. And we underdose it a little bit because we're using thrombolysis. So for younger patients, we will load them, but the load's only 300 milligrams, and then we continue 75 a day. Older patients, we do not give them a load. We just start with 75 a day. And we treat for usually up to about a year, although technically speaking, the lytic studies that showed a benefit of clopidogrel may have treated patients for only 2 weeks. Right. Now, anticoagulation, most patients who get thrombolytic therapy will be treated with unfractionated heparin. Some could receive enoxaparin or fondaparinux. Now, I know we don't use these agents very much in the United States, or at least in certain places in the United States. By letter of the law, if you're going to be using enoxaparin or fondaparinux, you're actually supposed to start with an IV bolus, which is something that most of us don't regularly do when we use those agents. Again, much more commonly used in Europe, where they do use a fair amount of IV enoxaparin. And then, if you're taking care of a patient in the ICU after they get thrombolytic therapy, most of the time, we're using this pharmacoinvasive approach, which means we're transferring most people for elective cardiac catheterization 3 to 24 hours after lysis. So not immediately, but within the first day. But if for some reason that's not done, you're in a place where the practice is to observe these patients and maybe do a symptom limited stress test before they go home. If they develop cardiogenic shock or acute severe MR or acute severe heart failure, if they develop recurrent spontaneous ischemia while you're watching them in the unit, they're patients who we should be transferring for angiography. All right. So while you're putting the norepinephrine up or getting another echo to look for an acute VSD or acute MR, you would be making arrangements to get them somewhere where there's a cath lab. Yeah, we can do everything here. I just mean in general. Yeah. So actually, we don't. So for those of you who aren't familiar with it yet, so we've had a cath lab here since the institution opened, but it was only a diagnostic lab until 2013 or so, and then we started doing primary PCI. And then about a year ago, New Jersey changed their regulations, so now we can do elective PCI as well. We cannot do certain high risk elective PCIs because because there's no surgical backup. So the state doesn't permit us to use certain types of devices that you would use in highly calcified lesions, for example. My group, we have a number of interventionalists and we all work here and at Cooper. So what we'll do is we'll take our own patients up to Cooper if we have that type of high risk intervention. There is another cardiology group here. They don't have any interventionalists. They generally will have us do their procedures. But if someone has a high risk lesion that we don't think should be fixed here, they may end up sending those patients to Philadelphia. All right. But for the most part, everything gets done here. What's that? So pacemakers can be put in here. There's no EP lab. So EP studies and defibrillators and certain higher level pacing interventions like biventricular devices and what's becoming even more common are left bundle pacemaker implantations. Those aren't done here either. We try not to do elective pericardiocentesis here. We've done plenty of emergent ones in the cath lab and at the bedside. The surgeons here aren't completely comfortable with it. Some of them do it. But if there's something like an RV laceration or perforation or something that's bleeding, they may not be equipped to repair that. So we try to send all the elective pericardiocenteses and elective windows up to Cooper, although we do plenty of emergent pericardiocenteses here. So I think that's the spectrum of what we're doing in the lab. Okay.
In terms of device, you guys make pumps and
Right. So that's a good point. I forgot about that. So we'll put in balloon pumps regularly. We will leave patients with balloon pumps here most of the time, unless we're putting them in and we think they need bypass, right? Impellas, we usually don't leave here. If we put an Impella in, it's not to support a high-risk PCI. It's usually for a patient who's in shock. And if we feel they need an Impella, we will usually send them to a tertiary so that if they need to be upgraded to ECMO, they can. Now, technically, there are mobile ECMO teams that can come down and put people on ECMO here, but I think it's probably safer to get the Impellas up somewhere where they can be transitioned to ECMO a little bit in a slightly more relaxed fashion rather than doing it here while they're crashing, trying to do it at the bedside while they're crashing. So you may see some Impella in the ICU, but usually they'll just be parked there until they get up somewhere else. Now, my understanding though is you guys have some rotations where you'll see more of that. So, all right. All right. So getting away from the thrombolytic therapy, since that's not something we do very often. I'll just mention our adjuvant therapy when patients undergo primary PCI. Okay. So everyone gets an anticoagulant. All right. There's two anticoagulants that can be used during STEMI. All right. Heparin and something called bivalirudin. All right. So bivalirudin, the trade name is Angiomax, is a direct thrombin inhibitor. There are guidelines that support upfront use of bivalirudin in the ED or on the floor, but it's an expensive drug. And over the course of the last 20 years, the benefit of bivalirudin, which was largely in minimizing bleeding, has lessened because for a couple of different reasons, but the two big reasons being that we use a lot of radial access now, and we don't use a lot of glycoprotein 2B3A receptor blockers. So heparin is probably just as safe in those contexts, probably just as effective or more effective in terms of preventing recurrent ischemic events, and it's a lot cheaper. All right, so most patients get unfractionated heparin. Now, we often use bivalirudin in the cath lab because it's easy, right? And it doesn't require dose titration, and you don't have to monitor coagulation. But you're not going to see it used in the ED, and you're not going to see it used in patients who are coming out of the cath lab unless we decide just to run the drip out, which we do sometimes. It takes a few hours. You may want to keep it in the back of your mind, though, because it's a real good drug for patients who need anticoagulation and have heparin-induced thrombocytopenia. All right. Normally, you use, some hirudin analog like Aggrastat. I'm not Aggrastat, sorry. Like Agatroban. But I don't understand why bivalirudin hasn't caught on, for use in HIT because it's so much easier to use. It doesn't require any titration. It's so much safer. It's out of the system in no time at all. But it's probably an expense thing.
Very expensive.
Yeah. Okay. So if I go groin, if I decide I want to use a glycoprotein 2B3A receptor blocker, I'm almost certainly going to switch from heparin to bivalirudin in the cath lab because it's a little safer and the bleeding risks are lower. All right. In terms of antiplatelet therapy, obviously everyone gets aspirin, and then everyone gets one of the three P2Y12 inhibitors. All right. So clopidogrel, it's a 600 milligram load and then 75 milligrams daily. Ticagrelor, which is Brilinta, is 180 milligram load and then 90 BID. And then prasugrel is a 60 milligram load, and then it's about 10 milligrams daily. All right. So the deal is ticagrelor and prasugrel are both a little better at preventing ischemic events, but they're also associated with a slightly higher bleeding risk. All right. So the vast majority of patients, we're going to use either ticagrelor or prasugrel, unless we think they're at very high bleeding risk, or we know that they're going to need an oral anticoagulant also, or we know they can't afford ticagrelor or prasugrel, which are both more expensive. You'll see a lot more ticagrelor being used. I think the reason is there is evidence to suggest that patients who are treated medically, who end up not needing a stent, get a benefit from ticagrelor. Also, in the clinical trials, ticagrelor was studied in such a way that you can give it up front prior to cardiac catheterization. And number three, it doesn't have any important contraindications. Prasugrel has really only been shown to be beneficial in patients treated post-PCI. And because of a higher bleeding rate with bypass and a longer amount of time to get it out of one's system, it's recommended not to give prasugrel until you've already defined the coronary anatomy. All right. Finally, you have to avoid it in patients who have very low body weight, who are over the age of 75, or have a prior history of CVA. For all those reasons, prasugrel sort of went out of favor and ticagrelor went into favor, but ticagrelor has more side effects. And there was a clinical trial, a head-to-head trial with a lot of methodological flaws that surprisingly showed prasugrel was maybe even a little bit better on protection and wasn't any worse in terms of bleeding. So in patients who are young, who have normal or high body weight, who have normal, hematologic parameters, and who I don't think are at high risk of bleeding, with no history of stroke, I'll often use prasugrel, and I'll tell the ED, don't give Brilinta. I'm going to take a look at the coronaries, and if if the patient doesn't need surgery, if it's a primary PCI, I'm going to give prasugrel. Yeah, I'll come back to that one. All right. Um, so glycoprotein 2b3A receptor blockers. Um, so integralin is the one we have on formulary here. Integralin, which is eptifibatide, and aggrastat, which are tyrosine, are the small molecules. Bixaban, which is ReaPro, is a larger monoclonal antibody. They have some slight pharmacologic differences in that the monoclonal antibody, you can sort of reverse its effect by giving platelets. So there's some thought that it may be a little safer. Fortunately, these medications are really not standard of care anymore. They're still used in very high risk patients or in patients who have a very large clot burden. Okay. But they were studied before we had ticagrelor, before we had prasugrel. And now that we have ticagrelor and prasugrel, there's probably less benefit of using a glycoprotein 2b3A receptor blocker, and the bleeding rates with them are much higher. Although, again, with radial access, there's less of that. Now, so normally what you will see is you'll see heparin, or you'll see a patient who received heparin in the ED, got bivalvuloted in the cath lab, and then, it either got turned off or, it just got, the bag runs out when they get to the ICU. Patients will get aspirin. They'll get either clopidogrel or ticagrelor. Once in a while, you'll see prasugrel instead. And then very rarely will you see patients getting a glycoprotein 2b3A receptor blocker. Cangrelor, and I think I have a slide on it a little bit later. Cangrelor is an intravenous P2Y12 inhibitor. All right. It's most analogous to ticagrelor. Okay. And it's got a very, very rapid onset and a very, very rapid offset. All right. So one might think, hey, listen, Cangrelor is a great option to use up front if we don't know if a patient's going to have surgical disease or not. That's true. All right. It's also a really good option for patients who are comatose and maybe can't get oral medications. Right. The problem with it is really, really expensive. So it's very limited in both at Cooper and here. All right. It is available, and we give it in two circumstances. All right. Circumstance number one is patients who are in the cath lab, are in shock, don't have good enteric access. We can't get an oral P2Y12 inhibitor into them. And number two is patients who have had a recent intervention, require urgent or time sensitive surgery, and can't receive, have to stop their dual antiplatelet therapy and get bridged with Cangrelor. All right. It's been shown in a clinical trial to be a successful strategy for patients being bridged for bypass. By, extrapolation, we think it's reasonable for people who may be going for non-cardiac surgery. Now, all that being said, nowadays, most of the time, if someone needs surgery immediately after stenting, we're pretty comfortable doing it on dual antiplatelet therapy. And I can remember 1 or 2 times when I had to use Cangrelor in the cath lab. Most of the time we can get the oral stuff in. All right. One other quick thing about Cangrelor, if you're in a position where we do use it and we do send the patient up from the cath lab to the ICU on Cangrelor, you have to be very careful when you're converting Cangrelor to the oral medications. I can't remember the exact pharmacologic reason for this, but you actually have to stop the Cangrelor and wait a little while before you start clopidogrel or prasugrel because they compete with each other. So if you load someone with clopidogrel when they're already on full dose Cangrelor, clopidogrel is not going to work. And then, it's going to be a few days before they get their levels up, right? That isn't the case with ticagrelor. And again, I can't remember the exact pharmacologic pathways for this, but you could give ticagrelor up front, right? So if we're on Cangrelor, the best option is to give the ticagrelor when you're shutting off the Cangrelor. But if you have to use something different, then you have to wait a couple hours and just deal with the fact that you may be uncovered with antiplatelet medications for a couple of hours. Mm-hmm. Yeah. Yeah, we have to order it. In fact, it came up last week, and there was a guy this was actually kind of a dumb question, but no dumb questions, right? Just dumb people. No, no, I mean, people don't know, right? I mean, but the problem was the guy had a post-operative MI like a month and a half ago, like after prostate surgery, had an anterior wall MI, and we stented him. And then and then he came in with probably appendicitis, right? So they wanted to take his appendix out, and they wanted to maybe stop his clopidogrel and bridge him with Cangrelor. That was the question for us. Now it turns out they decided to take him to the operating room the next day or later that day, so it became a non-issue, right? But I called pharmacy and they had to figure out how many vials we had and where it was. And so yeah, I mean, if you guys are in a position where you want to use it, it's not like it's ordered so frequently that you like cardiologists are ordering it all the time, but it's restricted to everyone else. We can make sure you guys get it. It'll be a matter of calling the pharmacy and figuring it out. And for someone who's had a GI bleed, and they're sort of resolving their GI bleed, and they've had endoscopy already, maybe they want to take a second look, but nothing was actively bleeding. That might be a good patient for Cangrelor, and we could certainly get it in those circumstances. You probably have to call pharmacy, and they would have to, yeah.
At least amongst our group, like if you're having a discussion with pharmacy to get approved for a med, we want you to document, why you ordered this med, justifications like patient at risk of bleeding, discuss with the pharmacy, so that it's not just you on your own, that it's you got some approval from pharmacy.
Yeah.
Because they want to approve the order.
They'll call you.
But they'll approve it if you call, but not otherwise just ordering it.
Yeah. Yeah. I mean, well, yeah. I mean, most, to be honest, it probably isn't going to make a huge difference in the middle of the night. I mean, a lot of it is institutional, right? So it sounds like they, were a little bit more enthusiastic and a little bit more permissive using Cangrelor where you were. And I wish it was like that here and in South Jersey. It's just that, it's expensive and it hasn't really caught on. It hasn't become sort of a therapeutic fashion, right? But chances are if someone comes in acutely with a GI bleed, they probably took their Plavix or their Brilinta that morning, right? You're going to be holding it. It's probably not a big deal if the Cangrelor gets started a day later because it's still largely in their system, right? So, okay. All right. Okay. So we'll move on to non-STEMI management. And you will be seeing a lot of patients with higher risk non-STEMIs. They often end up in our ICU. Right? I think STEMI management's pretty easy, right? It's reperfusion therapy and then put them on the adjuvant medications and watch for complications, right? Treating the complications is a whole other talk, right? But in terms of how to treat them initially, it's pretty straightforward. ACS is a little bit more complicated because there's such a larger spectrum of clinical presentations. So I like to think about ACS in 3 steps. Initial risk stratification, which couples very closely with the initiation of appropriate adjuvant therapy. Then choosing an invasive versus what's called an ischemia-mediated pathway, and then initiating the appropriate antithrombotic regimen based on that pathway. All right. So initial risk stratification and initiation of adjuvant therapy. All right. So before you're ever called on a patient, the ED, should be getting an EKG. They don't do this enough. They're better about it here, but a lot of EDs are not good about this, but they should be getting ECGs every 15 to 30 minutes if patients are still symptomatic. Troponin here is a high sensitivity troponin. Did you all train with high sensitivity troponins already? Yeah, most United States sites have switched over. So for the most part, with high sensitivity troponin, you can do a baseline and then a 2-hour high sensitivity troponin, and then in certain cases repeated at 4 to 6 hours. That's what the most recent consensus document suggests. And then applying risk scores. Some things that are often missed, okay, posterior leads. I think posterior leads can be very, very useful in patients who have ongoing persistent angina-like chest pain with elevated biomarkers, but non-diagnostic or normal ECGs. And we have picked up a few true posterior MIs getting posterior leads. Continuous 12 leads are probably not that helpful. BNP levels are often added. They may or may not help with risk stratification. And then the complex risk models like the TIMI score and the GRACE score should probably be used in patients with, definite ACS. This is just a table form, and these guidelines all come from the ACC documents. And if you guys aren't familiar with the ACC documents, they're good to get familiar with, as opposed to some of the other professional societies. The ACC really overdoes it with their guidelines, and they read like textbooks, and you can get them off the ACC website. So they are, very, very useful for various types of cardiovascular disease states. Now, I won't spend too much time on high sensitivity troponin, because my hope is that if patients are getting to you guys, they've actually ruled in and they have a real disease process, and they're not, coming, to you for, the reasons that we would normally send someone to an observation unit, right? The point I want to make about high sensitivity troponins, though, is that they have an excellent negative predictive value, right? So if a high sensitivity troponin is normal, meaning like undetectable, and serial, studies, or one study several hours after the onset of chest pain is completely normal, that essentially rules out an MI. But the positive predictive value is not very good, right? So, we use high sensitivity troponin to rule out MI. When we see elevated high sensitivity troponins, it absolutely has to be in context, right? So this is sort of the framework that we look at, on the left side, and these are patients who you probably will not see clinically while you're doing critical care. But if a patient has a very low high sensitivity troponin, or a relatively low high sensitivity troponin with no significant change in the troponin level, that essentially rules out a myocardial infarction. On the other hand, if the patient has a very high sensitivity troponin, or that high sensitivity troponin changes significantly, it says rule in. I think rule in is a bad way to think about it. Instead of saying that they rule in for MI, I would encourage you to think of that as an abnormally elevated troponin, and then you have to decide what that means. Okay. And, patients then fall into another category if they don't meet either of those criteria, right? We call that sort of indeterminate, or we put them in the observation, bucket, right? And in JACC, in the Journal of the American College of Cardiology from last year, there's really an excellent consensus document, which is surprisingly not boring, and goes through a real framework for understanding how to use these. So that's a good reference for anyone who has to deal with this a lot. I will say that if you have an abnormally elevated high sensitivity troponin, a lot of people look at it and say, well, it's either a heart attack, right? Or it's a type 2 spill, right? Or a type 2 MI. That's actually incorrect. I know that it's a semantics thing, right? And maybe we don't care about, the actual semantics, but, just for academic reasons, I'll tell you guys what the truth actually is, right? So if you have an elevated troponin, it can be one of four things, right? It can be, or one of three things. It can be myocardial infarction. It can be chronic myocardial damage, and it can be acute myocardial damage, right? So acute myocardial damage, for example, may be seen in someone with acute myocarditis. They don't have an MI, okay, but they have a process that's causing acute myocardial injury. On the other hand, chronic myocardial injury can be seen in people who have end-stage renal disease, in people who have valvular heart disease, in people who have heart failure. They may have elevated cardiac troponin for that reason. When you look at MI then gets broken up into 5 different categories, and that's the universal definition of MI. And the important ones are really a type 1 MI, right, which implies plaque rupture or plaque erosion, or a type 2 MI, which implies demand-supply mismatch. But a type 2 MI is supposed to have an ischemic context, right? So if somebody comes in with a GI bleed and they have chest pain and EKG changes, that's a type 2 MI. If somebody with chronic heart failure comes in with no chest pain, their echo looks exactly the same with no new area of heart damage, their EKG looks normal, then that's chronic myocardial injury. All right. It's a semantic thing, but it also, I think, is a framework that allows us to think a little bit about the differential diagnosis, right? Okay. Most people are familiar with the TIMI risk score. This is what it is. It's a 7 variables, and more variables means more risk. The GRACE risk score actually prognosticates out to 6 months instead of 14 days. It's similar, except there are also some other things that play into it, like blood pressures and the GRACE score. Now, the heart score, and there are now modified heart scores, um, uh, also somewhat similar, based on history, ECG, age, risk factors, troponin, and the higher the score, the higher the risk of MACE. But it's important to understand that there's big difference between the scores. TIMI and GRACE were validated and designed to risk stratify patients with a working diagnosis of ACS and guide the aggressiveness of therapy, right? Whereas the heart score is really designed to assist with triage of chest pain patients in the ED. So if you're managing a patient in the ICU and you're looking at this patient, it's a Saturday morning, and you know that the cardiologist is going to be by in 6 hours and is then probably going to say, well, let's cath this patient on Monday. You may want to apply the TIMI or the GRACE score. And if you find that they're at very high risk for bad outcomes, you may want to get on the phone and say, hey, listen, maybe we should bring this patient to the lab a little sooner, right? Whereas, the heart score, you're not going to be using that in the ICU. They're going to be using that to help figure out whether a patient needs to be admitted, what diagnostic and therapeutic pathway they should go down. I'm going to skip this. All right. So, that's risk stratification, right? Now, adjunctive upfront medical therapy. When I was, at your stage of training, when I was a resident and then a fellow, the mnemonic that we used for chest pain was Mona, right? I don't know if they still teach that. I hope they don't. But everyone meets Mona, right? So it's morphine, oxygen, nitrates, and aspirin.
I think they're like Bonaparte or something.
Oh, what does BASH mean? Oh God, that's even worse, right? Because here's the thing, right? So morphine, okay. Morphine is the only narcotic mentioned in the guidelines, but there are some clinical studies that actually suggest that morphine may be harmful. Many people believe that fentanyl may be a better option. There are some issues using narcotics when it comes to, absorption of antiplatelet medications. I think that it's fine and appropriate to give narcotics to patients who are in pain from an acute coronary syndrome, but we do it carefully. We don't give everybody narcotics, right? Oxygen, all right. So oxygen is recommended if oxygen saturation is less than 90%, but or if there's respiratory distress, or if we think there's some consequences of hypoxemia. But there is some emerging data that suggests that oxygen may increase coronary flow resistance, decrease coronary perfusion, lead to higher mortality rates. This is probably with very high flow rates of oxygen, but we don't want to give oxygen to everybody. Now, everyone who comes in the ER gets some oxygen thrown on them, and then they come to the cath lab, and the nurses keep them on oxygen because we sedate them and they need it for sedation. I get all that. But ultimately, take it off of them, right? Because if their SATs are 95, 96%, they don't need to sit there on 2 liters of nasal cannula with the theoretical, chance that something can go wrong.
That is like a theoretical reperfusion free radical treatment. Just reperfuse the area, now you do some unnecessary oxygen with radicals.
There's a whole spectrum of theory as to why this would be. I totally agree with that. And then, yes, everyone does get aspirin, right? Beta blockers. So when I trained, everybody got like 5 doses of IV low pressure up front until the commit trial, the CCS, the Chinese cardiovascular study, was published around 25 years ago, somewhere around there, and showed that if you did that, you did prevent arrhythmia, but you also caused a lot of people to die, right, by putting them into cardiogenic shock. So you have to be very judicious in who you use beta blockers in, and it's usually going to be patients orally when you think they can tolerate them. You avoid it in very elderly people who are borderline hypotensive, people who are tachycardic. And we used to give it to try to reduce the heart rate, but now we know that if they're very tachycardic, they're probably compensating for a small stroke volume. So if we give them a lot of upfront beta blockers, we could potentially hurt them. So beta blockers are appropriate, right? Class 1, but you want to give oral beta blockers within the first 24 hours, and only if they don't have any of these potential contraindications. And it's class 3 or recommended to not give upfront beta blockers, especially IV, for patients who are over the age of 70, have systolic pressures less than 120, a heart rate greater than 110, or present with a late myocardial infarction, because they may be the patients who are more likely to have impending shock. All right. So just in the interest of time, I will tell you guys that this table summarizes everything in my previous slides. You can take a look at it. It's right out of the guidelines, and it's not anything you guys don't know, right? We give calcium channel blockers if we think it's vasospasm. We give everyone high intensity statins. We give everyone with a low EF, diabetes or chronic kidney disease, ACEs or ARBs. The thing that's sometimes overlooked is the tremendous benefit of eplerenone or spironolactone for patients who have a myocardial infarction with an EF less than 40%, plus either clinical heart failure or diabetes. All right. We often overlook that. So if you have a patient who presents with an MI, they're diabetic with a low EF, add eplerenone or spironolactone. Spironolactone is cheaper. That's why most people use it. Eplerenone is a little more selective, so you get less gynecomastia. All right. So with the last couple minutes, I'll just sort of burn through the idea of invasive versus ischemia mediated. So, invasive is when patients go to the cath lab, right? Ischemia mediated means they don't go to the cath lab unless they have recurrent angina at rest, they have objective evidence of ischemia on stress testing, or, once we do a modeling with Grace or with Timmy, we find that they're very high risk. The vast majority of the time, the guidelines favor an invasive approach for people who have acute coronary syndromes. All right. There are some situations where it may be not the best idea. Patients who have extensive comorbidities, people who have, an aversion to doing a procedure. But for the most part, most people go to the cath lab. The timing really depends on how sick the patient is. There is no real benefit to early, meaning immediate or within the first couple of hours or the first couple of days, which is great for me because I can still tell you guys on Saturday that we're going to wait till Monday, right? But, all kidding aside, it really depends on how sick the patient is. So, refractory angina, heart failure with new or worsening MR, hemodynamic instability, electrical instability. These are patients who should go within a couple hours, just like a STEMI, right? Lower risk patients, stabilized, troponins 200, echo looks okay, EKG changes resolve, pain-free on heparin and nitrates. Those patients can wait a couple of days. Now, they usually don't wait a couple of days. It's usually the next day, or if it's the weekend, within 48 hours. But, just the data shows that they don't have to go immediately. All right. But we absolutely want to hear about patients who are high risk and are not doing well. I took a non-STEMI to the lab last week. It was a patient who came in with, some dynamic EKG changes, who was feeling okay, who was feeling lousy for a couple of days, and he felt okay in the ER, and they kind of sat on him. Then he got worse. And, as soon as he got to the ICU, I talked to the ICU team, and his pain was getting worse. His EKG looked a little worse. We took him, even though he didn't meet immediate reperfusion criteria. So absolutely call us if you think someone, needs to go sooner rather than later. We may ultimately decide not to after we, have a joint discussion about it, but we'd always like to hear about it. And then finally, just the last little bit of information is choosing an antithrombotic regimen based on the pathway. All right. So this can be very, very confusing. And I used to hear from a lot of docs who would say to me, I never know what to do, because if I call and Dr. A is on for the cath lab, he'll say, give Plavix. And then Dr. B will say, don't give Plavix. And then Dr. C will say, don't give Plavix, but start Integralin. So the truth is, the guidelines actually have a lot of options. Okay. And to make it very, very simple, this is how I would think about it. Okay. Everybody needs an if they're going to the cath lab, everybody needs an anticoagulant, and everybody needs an antiplatelet, and ultimately dual antiplatelet therapy. All right. The anticoagulant is almost always unfractionated heparin. All right. However, just like with STEMI, enoxaparin, fondaparinux, not STEMI in the cath lab, I don't want to confuse you guys, but we talked about those agents before with lytics. But enoxaparin, fondaparinux, and bivalirudin are all options. All right. Now, for reasons that, have to do with cost and efficacy and availability, almost always unfractionated heparin is used. All right. In terms of antiplatelets, everybody gets aspirin. Most people should be treated up front with clopidogrel or ticagrelor. The problem is, depending on where you are, if there's a propensity for a lot of these patients to go for surgery, those medications, if they're given up front, will delay surgery. All right. My usual approach is, if a patient comes in and they're going to go to the cath lab that day or maybe the next day, I'll usually hold off on giving them ticagrelor or clopidogrel until they've gone to the cath lab. If they're very high risk, or if it's the beginning of a weekend and they're going to be sitting for a couple of days for one reason or another, then I may consider using something like eptifibatide, which is Integralin. Cangrelor here is a great idea, right? but it's expensive and it's restricted right now. Maybe that'll change in the near future. Um, but if they're going to be waiting that long and they're relatively high risk, and I have a sense that they're not going to need surgery, I may actually give them ticagrelor up front. So I try to sort of tailor what I'm doing to the situation. All right. But the formal guidelines would say give aspirin, give a second oral antiplatelet medication up front. And in the CURE trial, the benefit curve separated after 24 hours, which is why that argument was always made. And then give one of the 4 approved anticoagulants. Most of the time, it's going to be unfractionated heparin. All right. And then in terms of patients who are treated medically, I just want to point this out to you guys because there are a couple of options which may actually be better than unfractionated heparin. If you don't think a patient's going to go to the cath lab, he or she has bad renal disease and has told you there's no way that I'm having a contrast-based study, or, patient has had 1 million stents and says, I'm done, I don't want it anymore, or I have cancer, I don't want any invasive procedures, but you're still treating them, all right? They should get upfront dual antiplatelet therapy, so aspirin and clopidogrel or aspirin and ticagrelor. And in terms of the anticoagulant, the data is actually a little better for patients who don't go to the cath lab, who are treated with either enoxaparin or with fondaparinux, which is a Rixtra, right? A Rixtra actually is not even that bad in patients going to the cath lab, but the problem is in the clinical studies of a Rixtra, those patients had a lot of catheter thrombosis in the cath lab. So you can't really use it as a standalone agent. You got to change to something else in the cath lab anyway. So we really limit it to patients, and we barely give it at all anymore, but we would limit it to patients who have who are being treated non-invasively, right? But this might be an option for you guys if someone with a history of heparin-induced thrombocytopenia is being treated, right? Fondaparinux would be a good option. Enoxaparin would be a good option for people who may, have difficult IV access. So, you can't stick them for PTTs every, or for, heparin levels every couple of, hours. So there are some other options there for people who are going to be treated medically and not likely to go to the cath lab. All right. So in the interest of time, I'll kind of stop and we can chat if you guys have questions. The one thing that I'll just say to wrap up is that these guidelines are kind of old. All right. The STEMI guidelines are from 2012. The non-STEMI guidelines are from 2014. There are some more recent coronary revascularization guidelines from like 2 years ago, but they're not specific for acute coronary syndromes. They apply to stable ischemic heart disease, patients undergoing PCI, and patients who are undergoing CABG. All right.
Moving away from the term like STEMI, like
So not in the so I have a feeling that I think the easiest way to answer your question is I have a feeling that the next iteration of the guidelines are going to have a bunch of new terms.
Yeah.
And it's not just going to be that. There's going to be MINOCA, which is myocardial infarction with normal coronary arteries. They're going to try to get a little bit more granular as to what causes what. I have a partner. Yeah, one of my partners loves to talk about how the reason for all these acronyms and all these names is to keep, academic guys in business, right? There's this maneuver we use in the cath lab when we're doing like, bifurcating stents, where like if the stent's really big here and then the artery bifurcates and the second limb is a lot smaller, you put in a stent that matches both, and then you go and you use a bigger balloon proximally to get that part of the stent open better. And what it's called, the proximal optimization technique. Like, why do you need a term for that, right? It's like, all right, you have to pot that now, and it's we all do that. I mean, you don't really need a term for it. So it may get a little bit it may get a little bit ridiculous, but we'll see what happens when we get the next iteration.
It's like we're seeing it a lot more now too. It's like we're finding a lot of STEMI equivalents that technically don't meet STEMI criteria, and I know that's always like an interesting conversation to have with you guys, right? Like we're seeing a patient and we're calling you guys about them, and it's yes, on paper, they absolutely don't meet STEMI criteria, but like, maybe it's a new left bundle branch block, maybe it's like the AVR ST elevations, like something, you know, that
Yeah.
STEMI equivalent.
Yep. That Jack paper I mentioned that goes through all the new stuff, about high sensitivity troponin, it actually has a really nice table in it with a description of all the STEMI equivalents. And also a good description of all the EKG changes that are more and less likely to be ischemic changes. So, I mean, you're right. STEMI makes it easy to, in a sort of binary way, say, is this patient appropriate for immediate reperfusion therapy or not? And that's easy for, EMTs. It's easy for ED docs. But when it starts to get a little bit trickier, that's when we have to start using other tools, right? And probably the best tool, right, is a point of care ultrasound, right? I mean, if somebody comes in with a new left bundle branch block and they have, you do a quick, and they have some chest pain, and you do a quick, bedside ultrasound, and their anterior wall isn't moving, but the rest of the heart looks good, then there's a very good chance that's an anterior wall MI, right? On the other hand, if their heart's pounding away, it's not. And if they have global hypokinesis and their EF's 10 or 15%, probably they have an underlying myopathy, and that's why they have a left bundle. It's probably not a STEMI. So, I think, serial, in a situation like this where it's really unclear, clinical context, serial EKGs, posterior EKG, point of care ultrasound, that's going to give you a much more precise diagnosis than simply STEMI or no STEMI.
Really, really good and point of care ultrasounds that way. You're really, really convinced, like it would help give them more data too. Especially if it's the middle of the night.
And it's a great tool for you guys for a number of different things, right? I mean, in the ICU, you use it for everything, right? I mean, I wish I had trained with ultrasound. We didn't even, I didn't train that long ago, right? I mean, I finished my fellowship in 2009. I finished my residency in 2003. 2004, I did a chief year. So, it's not like I trained so long ago, but we didn't even use ultrasound regularly to put in lines back then, right? I mean, it was first becoming a thing when I was finishing up residency. So, every now and then somebody would run and find an ultrasound, but they weren't, now it's like, I mean, not only is it standard of care, but like, it's so much easier. Right? Like, I don't need to use it in the cath lab, but I do regularly because it's easier and it's safer, So, but I think that, point of care ultrasound is a real big tool for figuring out patients who, are potentially higher risk.
Yeah, actually, so you mentioned there's a paper on the STEMI equivalent.
Mm-hmm.
You submitted
That's not
that.
it. Yeah, I know what you're talking about.
Yeah.
And what's the protocol for coach STEMIs?
Yeah, we usually do a separate talk on that.
Oh.
So, it's I'll walk you through it really, really, really fast. So the deal is, when we activate a code STEMI, whether it's an in-house STEMI, which is rare, or or an ER-based STEMI, which is much more common. Okay. The STEMI team responds, right? So the STEMI team is the cath lab nurses and techs, the interventionalist, and the interventionalist is the one who activates the lab, and then the critical care team. And usually it's the critical care fellow, although, the critical care, if you guys are busy, right, after you've assessed the patient initially, it's perfectly reasonable to leave one of your residents with the patient for the time being, right, if the patient's relatively stable. Now, one of the problems we have here is that, it's such a remote area, right? When we actually got approval for STEMI management, New Jersey, granted us 120-minute door to balloon time because of the location. Now, that's still actually in the licensing, but we want to do 90 minutes, right? It's better for patients and it's more consistent with ACC guidelines. So in order to meet these goals, we get the patient to the cath lab before the team, well, not before the team arrives, but even before the interventionalists arrive. Now, most of us who cover this lab also cover Cooper and we cover Jefferson. So we're all centrally located, and we can't, because we cover so many different spots with Cardiac Partners being an Inspira Cooper relationship, we can't park someone down here, unfortunately. So what ends up happening is you'll respond to the code STEMI, right? And then you guys will do the initial upfront management, right? Put the patients on the right initial medications, okay? And then go with them to the cath lab, all right? Now, the cath team will be there, and when the interventionalist arrives, all right, depending on the acuity of the case, you guys may go back up to the unit, or you may, hang out, right? If you guys hang out, we generally will go over the case afterwards. Now, there's usually three different situations, right? Like there are situations where the patient's really unstable and we need someone to, who has expertise that we don't have to manage their airway and things like that, right? And we've had cases where we've had the full critical care team and the interventional team all working together. There are other situations where you guys are pretty busy, the patient's pretty stable, we do a handoff. I'll take over, do the case, and then I'll hand back off to you when the patient goes up to the ICU. And then there are situations where you guys aren't busy and the case isn't complicated, but you hang out and we teach you what we do and we show you the cath, and and if there's a right heart cath, we have you guys scrub to do the right heart cath, or if there's a TVP, we have you guys scrub to do the TVP, or something like that, right? So usually you won't have to talk to the interventionalist up front, but you'll respond to the code. You'll do the initial upfront management. You'll accompany the patient over the lab. You'll manage them in the lab, and then the handoff will depend on what else is happening in the hospital and how the patient's doing. All right. Then you manage the patient in the ICU afterwards with cardiology, usually as a consulting service. All right. Now we do a handoff afterwards, and sometimes it's really easy. It's like, hey, this patient's fine, right? But sometimes there's a balloon pump. We may be, Impella and thinking about transfer to a tertiary care center. And then, we sort of review everything at the bedside and decide what the next couple of management steps are going to be. All right. So that's sort of a summary of it. All right. Now we actually, so the issue, this comes up every place that has a community-based STEMI program. There's this sticky issue with consent, right, for the procedures. So, I don't personally believe that informed consent in STEMI is really possible, right? Because patients are, oftentimes pre-treated with narcotics before any of us see them. Sometimes they're in shock. They're in really bad distress, and it's really hard to have a true informed consent conversation with them. I've spoken to legal about this before, and basically what legal has told me is that for an emergency procedure like this, you don't really need consent, but you should try and do as much of it as you possibly can. And, ultimately, it's permissible for anyone involved in the team to have these discussions with the patient. But ultimately, the proceduralist is the one who is legally liable for complications, which I think is sensible and it makes sense. So we developed this system of pre-consent, right? So we changed around our consent forms so that, and this is how they were doing it up at Cooper. This is how we got the idea. We changed around our consent forms so that, any member of the team, an emergency room doctor, a fellow, who's been educated on it, can go over the procedure to some extent with the patient, have them sign the form, and essentially sign as a witness. And then the proceduralist, when the patient's prepped, and, that way there's no delay in getting them prepped, confirms that they understand or that they're to sedate it or whatever to understand, and then signs off on it. And that pre-consent seems to work pretty well. They're developing a STEMI program now at Washington Township in the Jefferson system, and they're going to be doing, instead of that, they're going to be doing verbal consent, right? So the patients will be brought over to the cath lab and prepped ahead of time. It'll be explained to them en route. When the proceduralist gets there, he will or she will confirm all the details with the patient and then begin. It'll be purely verbal consent. We're still sticking with the written stuff, but the point is to try to explain the procedure as best as we can in a situation where informed consent is kind of impossible, right? So I have a lecture that I do with you guys going through cardiac catheterization, what the complications are, what the rates of complications are, how the procedure works, not just for educated purposes, so that, you can explain it to people, because, most of the time, whether it's you or an ED doctor or a clinical cardiologist, most of the time, the first point of contact is not the proceduralist, right? And then by the time the proceduralist gets involved, the patient is already received narcotics. The patient's already, in a position where, they're not, they don't want to, or they can't clinically sit down and have a 10-minute conversation, like if you were going to see somebody for an opinion on whether to get your hip replaced, right? So that's sort of how we've handled that. It all makes sense? All right. Does have any other questions? All right. So you guys can call me at any time if you have any problems at all. All right. There are 7 of us, soon to be 8, who do interventions for, my group is a private group, but we're the only ones who do interventions in Vineland. Okay. And we have another, 5 or so clinical cardiologists who are the ones who usually make rounds. A couple of the interventionists make rounds once in a while, but it's usually our clinical guys. You'll get to know everyone pretty quickly. You guys can call me anytime, right? Someone has my cell phone, probably a few of you guys have my cell phone. So you can call me anytime, whether it's cardiology related or related to something else. I'm also the president of the medical staff this year. So if it's something unrelated to, the cath lab or the cardiology, you can call me too. I'm a resource for you guys. Okay. And you keep my slides, and, we usually do a boot camp talk as well, sort of an introduction to the STEMI protocol that we touched on a little bit. And I'm happy to do a cardiogenic shock MCS lecture if you want. I can also bring my partners in to do talks on arrhythmias or other things that you guys would find interesting or necessary. Okay. All right. Okay.
Thank you so much.
You got it. Anytime.